Good afternoon. Thank you for the opportunity to present at this symposium today. My name is Karen O'Keefe and I work for Northern District Health Board as an improvement advisor. The improvement project I am presenting today was part of the Health Quality and Safety Commission's Safe Use of Opioid project that started in late 2014. Our project team's first challenge was to gain an understanding of how safe we were in our DHB in using opioid medications with our patients. As in many projects, we were keen to get on and do something. However, in the early stages, we really did not understand the scope of the problem that we were trying to solve. We did look at recent literature for guidance and reviewed some of the earlier work we had undertaken with our global trigger tool data. This clearly indicated that opioid presented significant risk to the patients. However, we initially struggled to understand the types of harm or the extent of the issue within our DHB. We spent a lot of our initial time in data mining and looking for indicators of opioid-related harm. We reviewed our incident data, complaints, naloxone use, and we investigated unplanned admissions to the ICU. None of these were particularly helpful. At the next stage, we sort of investigated, would coding data be helpful? This is a bit of a eureka moment for us. And we learned that by pulling data for patients with a Y450 code captured those patients who had experienced an adverse event related to opioids. Using this data, we were able to see the types of opioid-related harm and both categorize them and understand the frequency of events. From January 2014 to July 2016, we were able to identify 161 patients who experienced an opioid-related adverse event. These were all pulled using the Y450 code. We were then able to categorize these events and put them on a Pareto chart. The Pareto chart you're seeing there demonstrates our initial finding. We were quite surprised to learn that we had a much higher than expected number of respiratory depression events. It was also interesting to learn that despite seeing a significant number, that none of these ever appeared in our incident reporting system. The team at this point decided that we would focus on respiratory depression events. We were quite concerned of the safety of this issue, and that was the most useful thing that we thought we could do. We were able to quantify the frequency of these events by using a rare event chart. Our initial baseline data indicated the time between events occurring was at a median of 9 days. Again, we were quite surprised at the frequency of these events and that we really had not picked this up in any other way prior to initiating this project. In addition, we went back to the literature and starting to understand that. We found that using the term respiratory depression really didn't cover the events that we were looking at, and that we would actually move to using the term opioid-induced ventilatory impairment, and it was a more accurate description of the issue that we were trying to address. As we further reviewed the data, we recognized that there appeared to be two distinct population types that were experiencing OV events: patients in the operative pathway and patients in the non-operative pathway. At this point, we scoped the project further to focus on reducing opioid-induced ventilatory impairment events in the post-operative patient population. This did allow us to narrow our focus to a smaller suite of changes. We continued to develop our improvement theory by trying to understand some of the contributing factors and further learning about what the patients were experiencing, who was experiencing opioid-related events. The Pareto chart that we put out on this slide shows us that we were quite surprised to learn that those patients who were experiencing OVA were of the younger age group bracket. In addition, we were surprised to see that although our gynae patients are smaller volumes and numbers, they were seeing a lot higher number of opioid events related to other surgical cases. A further review of the cases helped identify a number of triggers that might predict OV events. We looked at longer stays in the recovery unit. We looked at any episodes of patients having decreased respiratory rates in recovery room, any evidence of excessive sleepiness, use of patient-controlled analgesia, and patients who had received higher doses of opioids through their perioperative period. We did review the data of opioid dosing and found that the patient group who had experienced an OV event had a much higher medium opioid equivalent dose they had received than a random sample of surgical patients of the same patient group size. The difference was in the OV group, they were having a medium opioid equivalent of 111 milligrams, and the non-OV patients were 61 milligrams. So our initial change ideas were to identify those patients who were at risk. We looked at patients that were undiagnosed with obstructive sleep apnea. We looked at improving communication on the opioid doses given in the operative period. And we also looked at risk mitigation and clarifying treatment guidelines and about how we would use naloxone and creating naloxone guidelines. Slide you're looking at was an example of a sticker that we used as a way of communicating total doses of opioids that patients had received. The next slide is showing us the stop bang that we process that we used in the perioperative process to look at people who had an indication of obstructive sleep apnea. Our learning from our first iteration of changes, what the things that our key findings was that the stop bang process and doing that early in the perioperative process was effective and it was easily done. We got good compliance with that. We found that we did have improved communication and awareness when patients were receiving large doses of opioids, and the stickers were being effective that way. We found out that we did need better monitoring for patients on patient-controlled analgesia. We found it was difficult to reliably identify those at risk of an OV event. And we also found that there was a real gap in knowledge about recognizing OV. We found that there were some practice gaps in effective monitoring of sedation scores, and that we realized that we had very limited access to other monitoring equipment such as SpO2 monitoring or end-tidal CO2 monitoring. Our outcome results, however, were very encouraging with our first iteration, and we did see an increase in time between events. So we were encouraged and we moved forward with updating our theory. So we looked at further change ideas. Some of the initial change ideas that we came up with was a significant education program around recognizing OV, the risk for OV, and how to early detect it. We looked at dosing guidelines for acute pain management and monitoring requirements for those receiving opioids. We improved the guidance on sedation score monitoring for both in PACU and in those patients having a patient-controlled analgesia. We also revised some processes related to people undergoing gynecological surgery. One of the key messages that we used and a real focus of our education was about over-sedation, and that one of the key indicators was falling asleep mid-sentence or rapidly drifting off after being roused. And that was one of our key messages that we really pushed. We continued this improvement work and we continued on following the end of the collaborative. We now have data, and this is up-to-date data from the end of 2020. And what we have found is that we have had sustained changes over the last 2 years. We have gone down from an initial median of 9 days between events to now a sustained effort of between 55 days between OV events and postoperative patients. We also have not seen a significant harm event from OV in this population for over 4 years. This remains an ongoing effort, and we are just in the process of reviewing patients who have experienced an OV event and compliance with our current guidelines. We are seeing that we have some things that are really stuck well, but there's further work to be done. We understand that we've still got some work to do with our use, reliably following our guidelines for naloxone use, and continuing to get compliance with our prescribing guidelines. So that will be ongoing work as well. The recent changes that we've undertaken, we have just adopted using a modified Pacero sedation scale and integrated this into our EWS chart using the AVPU section. We are also just about to roll out a new PCA pump with an integrated end-tidal CO2 monitoring. We were able to advocate strongly when we were replacing our pump fleet to be able to include end-tidal CO2 as part of this project work. Thanks for listening. I would like to acknowledge all the team that have supported this week. Our painting and medication committee have been key to our progress, and I'd like to thank HQSC for their initial focus, and it was a great benefit to our DHB.